Hello everyone, this is Doc ID. So today I am going to tell you about a big study that came out of New York. This was published in JAMA. JAMA is the Journal American Medical Association, and this study is the outcome data from first largest case series with coronavirus disease in the US. So this is going to be exciting. It is the first study that we have since data has come out from China. Now we have stuff coming out from the US. Now this again, first study. So we'll talk about it. Subscribe below. Please hit the notification. I'd love to hear some comments, feedback, questions that you may have about these studies that we're going to start presenting. So before we start off with the study, I just want to go a little bit about where we get our studies from. I'm going to show you a few journals. I know it's in my slide as well that you're going to see, but this is JAMA, Journal American Medical Association. We also get our studies from the clinical infectious disease. That's where, as an infectious disease, I do, and as well as the New England Journal of Medicine. And then obviously there's Lancet. These are some really good medical journals that we get our information from. We then evaluate these studies and go forward. So let me just start off a little bit basics. First confirmed case of coronavirus disease in the US was in the Washington state, and this was on January the 31st, 2020. And according to these authors, the rate of infections in New York had exceeded any other state. As of April the 20th, they were up to 30%.
All right, guys, so let's start here. So as you can see on this slide, it says presenting characteristics, comorbidities, and outcomes among 7,500 patients hospitalized with COVID-19 in the New York City area. So this was the study that was published in JAMA, which is called the Journal American Medical Association, that was published on May the 26th, 2020. So from what we know right now, we just have had very limited information as to describing these particular characteristics and outcomes that we see. The last thing was done was a retrospective cohort study from China, where hospitalized patients were predominantly men with a median age of 56 years, 26% required ICU care, and they saw a 28% mortality rate is what they saw. So then we come to our study that we did in this that you see. Now, when we look at a study from these journals, we look at a couple of things. The methods as to what was included in the study, what kind of patients were there. We saw the results, and then we usually discuss all of these findings, and the authors discusses as well as who published the studies. And then as physicians, we look at limitations as to, was this a good study? Was it just a study that kind of made some points but had a lot of information lacking from it, relevance lacking to it, and see whether this was truly a good study or not. So what did this study describe? And I'm just going to list these. I know you can see the slide. 5,700 patients. It was a good amount of people. 12 city hospitals. And what they looked at was the demographics of these patients, the comorbidities of these patients, what kind of clinical tests did they present with, and then eventually what the outcomes was. So then we go on to the methods. So everybody who required a hospital admission, they came into the hospital, they got admitted, had a confirmed SARS-CoV-2 infection by positive result on a PCR testing of a nasopharyngeal sample. Patients were admitted to any of the 12 Northwell Health acute care hospitals. So this is one system that had all the 12 hospitals between March the 1st and April the 4th. So it was a study that was only done in those particular dates. And we'll discuss that as we go on, but keep that in mind, that is kind of important. We go on to the clinical outcomes were monitored until April the 4th. Like I said, the end date for this study. Patients were also considered to have a confirmed infection if the initial test was positive or it was negative in the beginning, but then they repeated the test and it became positive. So really all the patients that were in this study did have a positive test, whether it was the first one or a repeat one done and it came back positive. We go on to a little bit I'm going to describe. I know it's a busy slide. Data collected included patient demographic information, sex, what female, male, race, ethnicity, comorbidities, which were multiple, and I'll describe that further down. Home medications, what they were on. Triage vitals, that's really when they come into the emergency room, the vitals that are taken. Then initial laboratory tests. I'm not going to bore you with this thing. This is more for laboratory tests that we look for coronavirus. When they come in, there are certain tests that are very, very classic for having the coronavirus. Now, if you're really interested, I would want you to comment on this below, make some suggestions, and if I see that a lot of comments to it, I may go do a lecture on just the laboratory test that we saw in coronavirus test. And then again, initial electrocardiographic results, diagnosis during the hospital course is important. Was it truly related to coronavirus, or did they come in with some other severe medical problems that we usually see in the hospital anyways? So these are things that you got to worry about. Inpatient medications, and then treatment. Did they really go on mechanical ventilation and dialysis, which is really kidney replacement therapy? And then the outcomes came out on these studies, which included the length of stay, how long they were in the hospital, did they get discharged, and then get readmitted in a couple of days, and then obviously the mortality, which is death. So now we jump into the results, as to I'm sure all of you are probably waiting for, and I'm going to try to go through these results, which is interesting, and then we'll discuss it, and then we'll talk about some limitations as well. First one, obviously 5,700 patients were included. Median age on this study of patients was 63 years old. 40% were females, 60% were males. Most common comorbidities that they saw in majority of these patients, you can see, is hypertension, high blood pressure, 56%, obesity, again 42%, and then diabetes, 34%. Now, there were other comorbidities which I didn't list here because the percentages were kind of low, divided in many different areas, which included cardiovascular disease, as I mentioned, hypertension, coronary heart disease, congestive heart failure, chronic respiratory disease included asthma, COPD, which is chronic obstructive pulmonary disease, obstructive sleep apnea, immunosuppression, HIV, history of solid organ transplant, kidney disease, again chronic, and then end stage, liver disease, cirrhosis, metabolic disease, again I mentioned obesity was big, diabetes was big, were other comorbidities that were there, but the three that you see listed above were the ones that had the most common comorbidities. So I'll break that down then to patients actually requiring mechanical ventilation as of April the 4th. Again, remember, it's March the 1st to April the 4th. Out of that study that they got, the patients, 3%, which is 38 patients, were discharged alive. 24% who were on mechanical ventilation died. However, as you can see that number, 72%. So 831 remained in the hospital. So that's a big number as well. So remember that. I'll discuss that a little bit. I know it's a little confusing on when you see this, but there was 5,700 patients that were in this study. However, only 2,634 out of those were kind of where we get these results from March the 1st to April the 4th. So it was not about the whole 5,700 patients. It was really those 2,634 patients. Since the study was ended on April the 4th, rest of the patients remain in the hospital. Mortality rates for those who received mechanical ventilations. You can see the age group of 18 years old up to 65, it was 76%. And if you're older than 65, look at that number, it jumped up to 97%. Mortality rates for those who did not receive mechanical ventilation. Again, mechanical ventilation is if you the machine was breathing for you. You got intubated, you had a tube in you. In that age group, 18 to 65, again, you can see 2% and then 26%. So you can see people who got intubated on the machine, 76 and 97 versus 2 and 26. So big difference there. So, and which we kind of see in our hospitals here as well. Patients who are on mechanical ventilation did have a much worse outcome, and I actually can agree those age groups look very familiar to us as well. Look at this, no deaths younger than 18 age group, so very positive. So what were the outcomes for patients who were actually discharged or died? Among the 2,634 patients who were discharged or had died at the study endpoint, again, remember I told you 5,700 patients, but 2,634 patients they actually got the results on, as the study was between March the 1st till April the 4th. 14% were treated in the ICU, 12% received invasive mechanical ventilation, 3% were treated with kidney replacement therapy, again dialysis. 16% of those patients were younger than age 50. 21% of the study of these patients, with 2,634 patients, died. You want to compare it to the China study that I had mentioned before, which was at 28% in the Chinese study that we had from before. 0% mortality for males and females patients younger than 20 years, which is great. So really that age group was good. Now again, I know we've been hearing about it in the news and other areas that younger patients have died, but those numbers are really minuscule. And in reality, again, it all depends on how many comorbidities you have. The more comorbidities you have, the higher chance of the mortality. But in this particular study, as you can see, it was 0%. Mortality rates were higher for males compared with females at every 10-year age interval than 20 years. So everything after 20 years, 10 years, males had a higher mortality rate. So let's go with some discussion about this study. These are what the authors feel that this study was relevant, and we can kind of discuss this a little bit. It was, according to them, the first large case series of hospitalized patients with confirmed COVID-19 virus. Older persons, again men, pre-existing diseases like hypertension, diabetes, again like I mentioned before, highly prevalent in this case series. Pattern was very similar to data from Chinese as well data. Mortality rates were lower, possibly due to differences in the threshold for hospitalizations. Findings of high mortality rates among ventilated patients are very similar to smaller case series of critically ill patients in the US, and I kind of concur with that, as we kind of saw very similar in our hospital, and we did see quite a bit. We were actually one of the highest hospitals with the highest rates of COVID patients that we treated in St. Louis, Missouri. And just to let you know what is mortality rate. So mortality rates, they're calculated only for patients who were discharged alive or died by the study endpoint. So we'll jump next to the limitations. I just listed a few of these. There were several limitations. One of them I saw was it only included patients within the New York metropolitan area. Another one was the data was collected from EMR. What's EMR? Electronic Medical Records. This precluded the level of detail possible within manual record review. So, and I kind of agree, because the EMR kind of just may not give you the complete data as to if you went through the chart briefly itself. and then you can see the clinical outcome data was only available for 46% of the admitted patients. So remember what I said, 2,634 out of 5,700 patients. So whatever the data you have is really for that 46% and not for the whole 5,700 patients that that this study initially started out with. So it does definitely has limitations to it, things to look at. I personally feel it's a good start as to what data we have currently. There are some things that I do see commonly occurring in our, at least in our hospital as well. I think more stuff is going to come out as we go to see what's going on with the data.
So that precludes the study that I discussed about. Once again, like I said, we just have to scrutinize these studies when they come out, whether the data is relevant or not. There's usually some data relevant, some not. So we really have to kind of keep things in perspective. Now, there is a new study that's also come out in New England Journal of Medicine. It just came out this month, and that's about compassionate use of remdesivir for patients with severe coronavirus disease. Now, again, this is one of the investigational drugs that you heard about in the media. So this is coming out. This will be in my next lecture, and we'll discuss about that at that time. All right, guys, so please don't forget to subscribe. Again, comment, feedback, and any questions that you have. Put your notifications on so that when these studies come out, we get some feedback together. This is all about learning. All right, guys, thanks.